speaker.
Thank you very much, Dolicia, for that kind invitation. Ladies and gentlemen, it is my honor to introduce our first speaker, Dato Professor Dr. Adeeba binti Kamarulzaman, the Dean of the Faculty of Medicine at University Malaya. She graduated from Monash and was trained in internal medicine and infectious diseases in Australia. She has established the Center of Excellence for Research on AIDS, known as CHERIA, that conducts multidisciplinary research on HIV, ranging from clinical to public health and policy research. She is currently the chairman of the Malaysian AIDS Foundation and also an executive council member of the Malaysian AIDS Council, the peak HIV NGO in Malaysia. Furthermore, she is presently an executive council member of the International AIDS Society and a member of the UN AIDS Scientific Expert Panel on HIV at the same time, an advisor to numerous WHO committees on HIV/AIDS. Today, she will be sharing on the topic, can we end AIDS in Southeast Asia? So without further ado, I would like to call upon Dato Professor Adeeba to give her presentation. Prof, it's yours.
Good afternoon, everyone, and thank you very much, Prof. Rusli, for inviting me and for the kind introductions. And okay, and also thank you, Professor Thomas, for that stark reminder that despite the COVID pandemic that has really upended the world, we still have this large problem of HIV/AIDS that we've lived with for the last 4 decades that hasn't gone away, and where there's much work to do. I'm going to share with you in the next 20 minutes or so about the HIV/AIDS situation in Southeast Asia and ask us all the question, can we end AIDS in Southeast Asia? This is because, you know, after 4 decades, it's taken a long time, unlike COVID, where in just under a year, we have diagnostic tools, we have incomplete treatment, but we have good treatment in dexamethasone for those who are severely ill from COVID, and we're soon to be introduced not just one, but very many vaccines, and this certainly been, you know, nothing short of a miracle for a newly emerging disease infection. Under 12 months, we have all that, and that, I guess, is a reflection of the urgency, the ease of spread, and the damage that COVID-19 has, or SARS-CoV-2 has done to the world. That's not to say that HIV/AIDS hasn't done equally large damage, having infected many millions of people, and many millions have since died as well. But after 4 decades, we do have good tools, we have good prevention tools, we have new and old, and we have good treatment for HIV. And we know that if we do the right things, we can in fact end AIDS. And there's a worldwide goal to end AIDS by 2030. So, you know, the question I'm going to share with you within the next 20 minutes is, but can we do it? Can we, despite having all those tools that we have now to end AIDS, can we do it? And if we can't, why? So, unfortunately, the situation in Asia is that we still have millions of people living with HIV. We have at the last count 300,000 new infections and 160,000 AIDS-related deaths. And we only have about 3.5 million people currently receiving antiretroviral therapy in our region. This is well below the rest of the world. And another tool that we have, which is the prevention of mother-to-child transmission, the science of which we had known since 1998. At present, only 56% of women who are pregnant and who are living with HIV have access to prevention, the antiretroviral therapy to prevent mother-to-child transmission. This is against the global average of 85%. So on that count alone, Asia and the Pacific is behind the global average. This is one area where we can be proud of. Malaysia and Thailand are the only two countries in the region that has achieved the elimination goals to prevent mother-to-child transmission of HIV. Okay, so globally, with the introduction of effective antiretroviral therapy, and as you know, antiretroviral therapy not only allows the individual to live a normal, productive life if they started on treatment early and they adhere to treatment as they should, but if they attain undetectable viral levels, then the possibility of them transmitting the virus to other people becomes very, very negligible. So this is the catch cry behind undetectable equals untransmissible. So therefore, the global goal of ending AIDS is on the premise that anyone who's HIV infected should know their HIV status, and that's the 95% goal, the first 95% goal. It used to be 90%, but it's been upped to 95% of people living with HIV should know that they're HIV positive. And having been diagnosed, 95% of those people should be on antiretroviral therapy, and 95% of those on antiretroviral therapy should achieve those undetectable levels. So if we achieve all those goals, then we will be able to stop the transmission of HIV or to end AIDS. So they're the 90, 95, 95, 95 goals. And we were doing, reasonably well, but globally, with a marked decline in new HIV infections and marked decline in deaths. However, even before COVID entered into our imagination, the Asia and the Pacific was not seeing the stark decline in new infections and deaths compared to even regions like sub-Saharan Africa, never mind the wealthy countries, but even sub-Saharan Africa. So Asia and the Pacific has seen a plateauing of new infections in the last 8 years. So we, even before the COVID pandemic, we fell short of the target of reaching, a decline in new infections by about 170,000 new infections. The fast track target that we set ourselves for Asia and the Pacific was 90,000 by 2020. Unfortunately, we had 260,000. We will have 260,000 estimated new infections in our region by 2020. Remember that these targets were set or were calculated before the COVID-19 pandemic. So where are those infections coming from? The pattern of global HIV epidemic can be divided into what's known as a generalized epidemic, meaning that the epidemic you see in men and women, and that's the type of epidemic that's seen in sub-Saharan Africa. In Asia and the Pacific, we have an epidemic known as concentrated epidemic, mostly amongst the key populations. These are buzzwords in the HIV world, key populations who are made up of, as you can see in that ring there, sex workers, people who inject drugs, gay men and other men who have sex with men, transgenders, clients of sex workers, and the remaining population. So in Asia and the Pacific, 98% of new infections are seen or are seen amongst members of these key populations. The large proportion of whom are 44% are amongst gay men who have sex with men, clients of sex workers, and people who inject drugs. If you separate this by gender, you will see that again, majority are amongst men who have sex with men. So among what we call cis male, 44% at the age of 25 to 49, and 15 to. So young men make up a large proportion of newly infected people with HIV in our region. So this is just to summarize what we know also, that unfortunately, although members of the key population are those most at risk, about half of them, about half of people who inject drugs, another half of sex workers, gay men and other MSM and transgender are actually unaware of their status. So remember, our goal was to get 95% of people who are living with HIV to know their status. So we still have some way to go. So what's some of the reasons why we are not seeing high levels of testing in our region? And here's an online survey. As you know, with the explosion of digital technology, a lot of people now meet in the virtual space. And we did, or my colleagues did this study using Hornet, which is sort of an MSM platform, and did an internet survey where 4,310 MSM from 10 member ASEAN countries subscribed to and participated in this survey. Now, despite being at risk, a third of them had never been tested for HIV. 50.7% responded that they had a test within the last 6 months to 2 years. Only a very small percentage had had a recent HIV test. So, and when we look at the results further, the younger they are, the lower the educational status, and those who are identified as bisexual or heterosexual and had never used a condom with a male partners, which put them at high risk, have higher odds of never being HIV tested. So paradoxically, those who are at higher risk are those who are not getting themselves tested. And one of the main reasons for not being tested is the low risk perception of HIV exposure. So we still have a lot of work to do to educate those at risk, even with basic information like get yourself tested. I mean, I'm really sad. I mean, this is very real, because this morning I was doing ward rounds at PPUM, and there were at least 3 young HIV positive men who, out of one side of the ward had 15 patients, so, and a mixture of HIV, dengue, and other infectious diseases. But out of those 15 patients, 3 had recently been diagnosed with HIV, young, under 25 years old, all with advanced disease and opportunistic infections. So it is very real. It shouldn't be happening because HIV is not like COVID, been around for many years. So all of us have still got a lot of work to do. One of the phenomena that's happening not just in Malaysia but in the Asia Pacific is this sexualized drug use, with amphetamine and other such drugs being commonly used. And again, this is a survey which showed how common Chemsex, as it's colloquially known, in this region. So in Vietnam, 20.1% of those surveyed had ever used crystal meth. In Thailand, 17.6%, Malaysia 7% in the last 6 months, Japan, and all those numbers, and so forth and so forth. And what these drugs do is it kind of creates some level of inhibition, multiple sexual partners, and increases the risk of transmission. So here is some recent analysis from the Global AIDS report released in the summer of this year. And as you can see here, Asia is not doing well at all in this testing, HIV testing and treatment cascade, the 95-95 goals. We're 75, 60, and 55. And the figures for Malaysia is not terribly different from this overall regional figures. And you may not be able to see this very well, but in most countries in the region, the proportion of newly diagnosed people and the CD4 counts, as you can see, once again, many countries in this region have people presenting with very advanced disease with CD4s of 350 or less. And you can see here in Malaysia, those present this light brown color is the predominant bar in Malaysia. The more advanced countries like New Zealand and Australia, overwhelmingly people present with CD4 350, or the majority present with CD4 350. But in most other countries in the region, it's the opposite, that most present with advanced disease, which makes treatment harder, and that makes returning back to normal CD4 possible, but a lot more difficult. And this, as I said, is really in a way depressing, because we have this bags of tools in both prevention and treatment that we've had for many years. Of course, education and behavior modification is difficult, as we can see with HIV as well as with COVID. We've had condoms forever. We've had clean needles and syringes. We've had methadone. And what we now have is also other biomedical prevention tools like PrEP, which is taking oral pills, somewhat like the oral contraceptive pills that can prevent the acquisition of HIV. Even more exciting, on the same day that the Pfizer COVID vaccine was announced, the results of HPTN-084 was also announced, where the long-acting injectable cabotegravir, another antiretroviral that was studied in a large cohort of patients of women in sub-Saharan Africa, showed that by getting these 8 weekly injections, it pretty much prevented HIV acquisition and transmission in more than 95%, I think, of women. And before that, there was another study called the HPTN-083, which also showed similar efficacy in preventing HIV acquisition in MSM as well as transgender. So, we certainly have the tools, both daily or on-demand PrEP, as well as now coming through injectable PrEP, as well as vaginal rings that can prevent HIV. So many things available to us, of course, including clean needles and syringes and condoms that could really potentially see us end AIDS by 2030. And on the left side, we have, seven groups of, 6 groups of effective antiretroviral agents. As you know, they have to be used in combinations, but effective it's even been brought down to 1 pill a day when you combine some of these tablets. When the protease inhibitors were first designed back in 2008 or so, when it first became available, some of you may recall that at the time patients were having to take something like 20-30 pills a day, but now the advances in antiretroviral medication means that they only need to take 1 pill a day that can suppress the viral load down to undetectable and therefore not transmit the infection to other people, even with condomless sexual encounters. So, you know, we're certainly not short of tools to prevent and treat HIV. Unfortunately, what gives me some pessimism as to why we're not going to be able to end AIDS by 2030 is, despite all those tools, despite all the clinical trials that shows that these things work, look at how woeful the coverage for some of these modalities. So in the proportion of this graph, you may not be able to see so well, the proportion of people reporting having received at least 2 HIV prevention services in the previous 3 months. The dark green denotes transgender people. So in Asia and the Pacific, except for Cambodia and Malaysia, most of the countries in the region, the people interviewed or surveyed said that they did not receive HIV prevention services, adequate HIV prevention services in the previous 3 months. And similarly, if we look at MSM, which is this light brown color, which at the moment are the group most at risk. Again, with the exception of Thailand, most countries have not done well. And the same with people who inject drugs. So most people surveyed, less than 50% of people surveyed say that they receive adequate HIV prevention services in the previous 3 months. So only Cambodia is doing well here with achieving 90% for transgender, about 80% for nearly 100% for female sex workers, because they've got the 100% condom campaign ongoing in Cambodia, and 70% gay men said that they've received adequate services. So it is not surprising that in our region, it's only Cambodia, Thailand, and Australia, if you count Australia in the Asia and the Pacific, count as the only 3 countries in our region who have achieved the 90-90-90 goals. And imagine that, Cambodia, who with a GDP much less than ours. But you can argue Cambodia is getting good support from the Global Fund. But Cambodia was also, a decade ago, the country that had one of the largest HIV prevalence and incidence. And now with a really comprehensive and well-funded response, they have really turned the tide of the HIV epidemic in their country. What about PrEP? In Australia, I was at an Australian parliamentarian breakfast seminar on World AIDS Day. Australia has roughly the same number of population as us. They have, scaled up PrEP, pre-exposure prophylaxis, all across the country, and have seen a huge decline in the number of new infections. I think for the year 2019, they had less than 800 new infections for the entire country, compared to us having 3,600 or so new infections. So what is the biggest barrier? We have all what we need. We have, a good health system that should be able to deliver all those tools that we need to have out there. But we're still not achieving our targets. And why this is so, I think all of you here would agree with me that the biggest barrier, our biggest Achilles heel, is the stigma and discrimination. And this is from a regional survey of people living with HIV, the stigma index. 61% felt ashamed, 22% avoided going to their local clinics, 11% actually had health services denied to them, and 7% were denied sexual and reproductive health services. And we have what we call the intersectionality of stigma, because already those at risk or those living with HIV have one layer of stigma by being either sex workers, men who have sex with MSM, transgender, or people who use drugs, ex-prisoners, migrants. So that together with HIV becomes multi-layers of stigma. This is from a study that my colleagues and I did at UMMC and also at UITM. There were actually two studies. One we did with medical and dental students, and one was with physicians. And when we say physicians here, we also mean surgeons and ONG and anesthetists, doctors in general. In the study that we did with medical and dental students, what we showed was the stigma index was highest against MSM, followed by people who inject drugs, followed by people living with HIV, compared to the general population. And then we went to repeat this study with senior doctors, including MOs, all the way to consultants. And indeed, there is still pervasive stigma with main drivers of discrimination against transgender people and MSM. Now, this is also a survey. This is a regional survey that was published in this recent Global AIDS report. When they interviewed ordinary citizens, the public, and asked a question, would you purchase vegetables from a shopkeeper living with HIV? Asked this question to 15 to 49-year-olds. 34.4% answered no, that they would not purchase vegetables from a shopkeeper living with HIV if they knew that that shopkeeper is living with HIV. So imagine this, 40 years down the road, and people still believe you can get HIV from buying vegetables from a person living with HIV. Some of the things that drive stigma even further is, I think, the structural drivers of stigmatization. And what I mean by that are the laws and policies that exist. So in this region, all 38 countries still have laws that impede HIV response. 37 criminalize some aspects of sex work. 11 have compulsory detention centers for drug use. 15 have the death penalty. 16 criminalize same-sex relations, and 10 impose some form of restriction on the entry, stay, and residence of people living with HIV. Added to all this pessimism, and those of you who know me know that I'm usually very, very optimistic, but added to this kind of pessimism, it's not to say that we still shouldn't work hard to end AIDS in Asia and the Pacific by 2030, but I think I've outlined this afternoon why it's tough. Added to all this is of course, the growing conservatism around the region, not just in Malaysia, but around the region, and I guess even all around the world. So these are charts to depict how much the laws and the policies exist to make it difficult to reduce the stigma and discrimination towards key members of the key population, because many of these are still criminalized. So I show this 3 countries, Thailand, Cambodia, and Australia, because as mentioned earlier, they're the 3 countries, the only 3 countries in the region that have achieved the 1990 goals. How does Thailand do it? Thailand is really, even the early stages of the HIV pandemic, of course, had the 100% condom campaign, but they've moved on till then. And one thing that we can really emulate from Thailand is the involvement of the community-based or peer, KP stands for key population or peer-led health services that stresses on accessibility, availability, acceptability, and quality. They really mobilize, train, adequately fund their community-based organizations to deliver not just prevention, but also treatment services for transgenders, for MSM, for their drug use programs are not as mature as their sexual transmission related programs. And what we also saw with the COVID pandemic is that these organizations were able to respond very, very quickly to mitigate against the disruptions that COVID led. So, we had plenty of examples of how one of the programs called the Thai Princess Prep program did online deliveries or home delivery of PrEP, of condoms, of HIV testing, and so forth and so forth. I have to say, we're very proud also of our colleagues here at the Malaysian AIDS Council and partner organizations that did similar response with respect, especially to clean needles and syringes. The partner organizations that were dealing with people who use drugs in the harm reduction program also did some very innovative changes to the program, such as giving more clean needles and syringes to the clients, given that they were not able to do outreach as frequently as the norm. What these key population-led health services in Thailand also showed the improvement in HIV testing, as well as diagnosis, as well as increasing the number of PrEP users once they expanded these health services into the community, rather than having the usual clinic-based or specialist-based treatment and prevention services. Similarly, in Vietnam, this was an NIH-funded study that tried to improve not just the prevention, but also antiretroviral uptake amongst people who inject drugs in Vietnam. And this is something that we desperately need to emulate, because although we've brought down the HIV infection amongst people who inject drugs, they're the group that's least likely to be receiving antiretroviral therapy right now. And what the study in Vietnam showed is that services that are delivered by peers in this study called DRIVE, giving needle syringe program, methadone assisted therapy, and antiretroviral therapy, they managed to reduce the HIV incidence to 0.1 per 100 person years, when their target was 0.5. They managed to reduce the percentage of HIV seropositive people who inject drugs who are not virally suppressed to 7.5%. and achieve the 1990 goals, and likewise reduce the percentage of HIV seropositive people who inject drugs not at viral suppression and not engaging in sharing needles to less than 1%. So these are remarkable achievements that we really need to emulate. So although I started off by with all doom and gloom that we're not going to end AIDS in Asia and the Pacific, there are plenty of innovative programs all around us, here in Malaysia as well, but in countries around us that we can emulate and get going and improve our 90-90-90 targets. This is another example of self-testing program using the index case to then motivate their sexual partners to do self-testing rather than bringing them in to a clinic for testing. So they can either go for lay testing or have it delivered to their homes and health facilities. By having this, by optimizing this index testing case, they increase the number of people who were getting tested. One program that we're going to launch or have launched in Malaysia is this HIV self-testing programs, where we invite people at risk to go to a website and be educated about testing and about treatment and about PrEP, and have the kits, the tests delivered to their homes. They do their own tests, send the results to us at the Malaysian AIDS Foundation and Malaysian AIDS Council, and be supported by a team of people who then can channel them either into treatment or into prevention. This has just started, and it's something that we hope will grow very quickly. The other innovation that we must do very quickly is the same-day antiretroviral therapy, so that we don't lose patients once they have been diagnosed with HIV. We need to start treatment as soon as possible, because remember, we want to achieve that undetectable viral levels so they don't pass them on to other people. This is something the Thais have also done. Now, what about those who are engaging in Chemsex? This is an example of a program in Taiwan where support is provided online or at the Hero Clinic. Unlike heroin use, Chemsex, we don't have the methadone equivalent or the buprenorphine equivalent, and so reduction in drug use relies very heavily on counseling and behavioral therapy. And so this program in Taipei is an excellent example of quite an effective program to mitigate HIV infections amongst people who use Chemsex. Okay. And finally, it's with all those laws that I shared with you that not only discriminate and stigmatize, but also worsen the HIV situation. So if we've been successful in reducing HIV in Malaysia because of the needle syringe program, because of the methadone program, that story is not enough, because the ongoing criminalization of drug use is part of the risk towards the ongoing infections that we see. So in my last few slides, I think both COVID and HIV infection have shown that what we need to, how we should respond is that we need to have a really comprehensive all of society, and that shouldn't just be a buzzword, it should really be an all of society response, whether it's COVID or whether it's HIV. And certainly the COVID pandemic has a lot to learn from the HIV movement in terms of how to deal with these infections. And one of the hallmarks of the HIV response have always been this community engagement, community activism, etc. However, for that to be really effective, civil society organizations have to be adequately trained and adequately funded to take on the role of service provision to all the groups, like what I've shown you is happening in many countries in the region. So what will it take to end AIDS in Asia? Number one is to know your epidemic and know your response. This is again a mantra in the HIV world. It's no use borrowing what is the approach in sub-Saharan Africa and use it in Malaysia, because we have a completely different epidemic. And likewise with COVID, it's no use emulating what people are doing in, let's say, the UK right now. They're doing terribly, but whatever they're doing doesn't really, it's not so relevant to us, because we have a different epidemic right now. Our epidemic we're seeing is amongst migrant workers and prisons, for instance. So that's where we should be investing all our efforts in. So likewise with HIV, we have an epidemic, a raging epidemic in young MSM currently. And that's where all our effort and investment should be. So that's what we mean by know your epidemic, know your response. It needs to be people-centered approach and integrated, and best illustrated by those civil society-based services that the Thais are doing, and peer-led. And just as the virtual space provides high risk for people to meet and increases the number of partners, etc., the answer also lies, I think, in the digital world in terms of providing accurate information and also effective delivery of services. We live in a conservative country. We can't have, use condoms on buses. We can't have sexual or reasonable sexual education in our schools, but we could be innovative and provide those same education digitally, where hopefully it kind of is a little bit more less in your face and a bit more acceptable to our conservative society. And likewise, the examples I gave you in terms of self-testing, that you register online, you get your kits delivered to you, then get support through telemedicine, etc. So that's where a large proportion of the answer to how we end AIDS is. However, it needs to be adequately resourced, and of course, all this will work best if we have a safe, supportive, and non-criminalizing physical and virtual service and environment. This is my friend Edwina Wright, who was featured in the New York Times in this article about how Australia could be one of the countries that will eliminate HIV, and they doing all they can to do that, and they really have led the way for the last 4 decades with very, very few annual infections, and it's because they have all these key elements in place, and that's a universal health coverage. They have many levels of leadership, from political will to academia, clinical, civil society, patient groups. They use science and research to advance policies, and of course, they have financially invested in all this response. And I think they firmly believe that prevention is better than cure. They invested, if I'm not mistaken, something like 1 billion to eradicate hepatitis C. But they've done the calculations, and they will get there pretty soon in terms of eliminating hepatitis C, and they're doing the same in terms of eliminating HIV. So if we want to get there, this is what it takes. As I've shared with you, we've still got a long way to go, but it's never too late. If this could be a rallying call to all of you who've not got involved, please get involved in any way you can, so that we can end AIDS in Malaysia and the region together by 2030. Thank you very much.
Thank you, Dato Prof. Adeeba, for the informative and inspiring talk. And I have seen some questions directed to Prof. Adeeba. And now I'd like to invite Prof. Bruce Lee to moderate this short Q&A session.
Thank you, Dolicia and Prof. Adeeba. That was a fantastic discourse on the HIV/AIDS. I think in this almost less than an hour, I learned a lot from you. I hope everyone has the same experience learning. And then, of course, there are a lot of questions that I noticed here. I will just capture some of the bigger one and perhaps try to combine. The first one, Prof. Adeeba, because this year the theme of the World AIDS Day is a global solidarity, shared responsibility. So the question is that could you kindly elaborate what does it mean by this this theme of the World AIDS Day?
Right. So, as I alluded to in terms of the COVID pandemic, for instance, what we've achieved in under 12 months could not have been achieved without that global solidarity, without the scientists coming together and sharing. Well, first of all, the Chinese shared the viral genome that allowed Malaysia, for instance, able to design the PCR back in January. And when you think, how many years it took for the HIV test, the diagnostic test to be available. So I think that is just one example of how we need to come together, and with global solidarity, we can overcome. So, and the second half of it in terms of shared responsibility, I think the other thing that both HIV and certainly COVID showed us is the world is now a borderless world, isn't it? Within months of the infections being reported in China, then you had it happening in Iran, in Italy, because of air travel and so forth. So if we don't view ourselves as a borderless world and not come together, then it's going to be very difficult to overcome this pandemic or other pandemics in the future. There are many reasons for global solidarity. For choosing global solidarity. One is, of course, the exchange of ideas, exchange of research. Those achievements that I've shared with you in countries like Cambodia, Vietnam, would not have happened and even Malaysia would not have happened without significant investment from the Global Fund and AIDS, TB, and malaria. So the Global Fund came together upon the suggestion of Kofi Annan and the UN, where countries put in millions of dollars into this fund, and that then gets dispersed to countries based on levels of incidence and prevalence. And we received, all in all, I think about 15 million in Global Fund, and in Global Fund terms, that's tiny. Countries get hundreds of millions, and that's how the success of the sub-Saharan African response through huge investments from Global Fund and the US PEPFAR program to scale up number of people on antiretroviral therapy. There are now 33 million people on antiretroviral therapy. When it was first mooted back in 2003, the 3x5 to get 3 million people on antiretroviral therapy. By 2005, the world thought this is crazy, it's not going to ever happen. But again, with that global solidarity, prices came down, and now we have, and money was put into the Global Fund and PEPFAR, and now we have 33 million people on lifelong antiretroviral therapy. And we need to increase that. Yeah. Sorry for that long answer.
Thanks, Prof. Adeeba. There's another question on the notion that HIV is looked upon as like a chronic disease, right? With immunodeficiency, and the idea was that would they be the one that actually will having higher incidence or greater severity of COVID-19 or even SARS, or MERS?
Yeah.
What do you think?
Yeah. So people are tracking this, and the results are quite mixed. there are some studies and reports from Western Africa where there is increased death in people living with HIV when they are co-infected with COVID-19. But there are also studies that quite relatively small numbers of, compared to the thousands of people who've been infected with COVID-19, co-infection rates are thankfully quite small, and it wouldn't appear to be that HIV actually worsens. Is worse or COVID is worse in people with HIV, but the numbers are relatively small.
And then the other one, Prof. Adeeba, this is looking at the impact of the pandemic, and the lockdown on the possibility of contracting HIV. Do you think there's any impact at all in this scenario?
Of contracting HIV or on the HIV programs?
I think the question was on the HIV contracting rate in various countries.
Right. So I think without a doubt, HIV programs have been disrupted all over the world. But as I said, loads and loads of efforts been taken to reduce the impact of it. So, whether it's making sure that antiretroviral therapy is not disrupted, making sure that PrEP delivery and all that. So there's certainly modeling studies that have been shown that speaks to there's going to be more infections and more deaths as a result of COVID-19. But whether this is actually true that we're going to see higher incidence of HIV, I think it's too early to tell. But modeling studies suggest that there might be as a result of all these disruptions to services.
There is a question, Prof. Adeeba, from I believe a HIV positive individual. The guy, I think is I know guy or girl, is already more than a year on HEART and believe that she is in denial. So the advice, what's your advice on this? What should they do, or what should he or she do?
Yeah, I think, there are a number of really great counselors around, including peer counselors, especially peer counselors. It does take a long time for some people to overcome the fear, the shock, the denial, the internalized stigma. So do reach out to counselors and organizations like the Kuala Lumpur AIDS Support Society. You can call Malaysian AIDS Council, you can call CLAS directly, and they will connect you to peer counselors who can, talk to you about this.
Okay,
or talk to your doctor.
Thank you. And the other question was more on the impact of homophobia and vaccine on these, on the rate of transmission for AIDS. Any thought on this?
The impact of homophobia. Okay. Did homophobia play a factor in the delay of eradication of AIDS when it first emerged? I think so. Yeah, certainly, or not just homophobia, but just AIDS in general, because it certainly took a long time. If those of you who are my age or older would remember that, when AIDS first emerged in the 1980s, it took the world a long time, and it took President Reagan, who had friends who were infected with HIV, to actually acknowledge, and I think it took him something like 3 years before he even uttered the word AIDS. So yes, yeah. So I think there was a delay, but you also need to remember that science has also evolved tremendously in the last 20, 30 years. So what some of the advances and that we are seeing that has been translated into COVID research and COVID diagnostics and vaccine and all that came from the intense development in science, some of which are due to AIDS, some of it due to cancer research, etc. So yeah, some of it because of homophobia and other general HIV phobia. But the other is it's hard to compare the two because one of the things is the development in scientific knowledge in general that has enabled us to respond much more quickly to COVID-19.
The next question, Prof. Adeeba, is a little bit more political. No? Is about the Malaysian AIDS Foundation NGO like class. No? How can they help the current government to develop the political will is similar to the one in Thailand?
Yeah, so I currently chair the MAF and class. I think Chris Lee chairs. Chris Lee is the president of Malaysian AIDS Council, and we do everything we can to try and convince the government. I must say that I think of all the local NGOs, I cannot complain that MAC does get a lot of support from the government, but we can do more. I mean, we get several million a year, but we should be getting much more, because I think by us and our partner organizations carrying out some of those important prevention and treatment services, in the long run, the government might be able to save money. And I'm speaking not just on behalf of HIV civil society organizations that provide direct service. I think there needs to be a government policy where good NGOs providing good services should be adequately funded. Whether it's HIV, whether it's the elderly, whether it's disabled, a lot of NGOs live hand to mouth, and it's really sad to see, because they are providing wonderful service that could reduce, for instance, admissions into acute hospitals and so forth. So we're quite blinded when it comes to the importance, meaning the country, of supporting civil society. And if nothing else, COVID should make us realize that.
Probably, but that is perhaps there's last three questions I may combine. No?
Okay.
Basically, the one is the vaccine. People have been asking, because vaccine now is the in thing for COVID-19. What about for AIDS? Vaccine. The other one is issue about PrEP. Is how good is PrEP actually? And the last one is that somebody was saying that in the actual prevention for HIV really is abstinence. So how do we go about? So there's three. I don't know how you tackle one.
Okay,
first.
All right. Let me start with the vaccines. So, a lot of investment in vaccines. Unfortunately, the recent large studies have been quite disappointing. I personally believe that we might be able to find a cure before we find a vaccine. There are many definitions of cure, and there's fantastic work going on to look for HIV cure, and I think we might get there before we get a vaccine. So there's plenty of hope, and there have been isolated cases, as you all know, of people who've been cured of HIV. The second thing, in terms of PrEP, many studies have shown the effectiveness of PrEP in large studies of MSM, of men and women and so forth. So extremely effective. The question is adherence. People may take PrEP for the first year, for 2 years, but they may tire of it, and that's why this exciting development in terms of injectable PrEP as well as injectable treatment, so that with 6 injections a year you could prevent 95% of people from getting infected. That's pretty exciting. You might not even need a vaccine. And lastly, abstinence. Well, whether it's abstaining from sex or abstaining from drug use, if every human being in this world could be all nice and good, we wouldn't have the problem we have right now. People can't even wear their masks properly, so let alone abstaining from sex and abstaining from drug use once they're addicted. So that's all I have to say to that.
Thank you, Dato, Professor Adeeba. That was fantastic, and I think we all have learned a lot from you, and hopefully that will, propel us to more active participation in what we have been doing around the world on
Thank
HIV.
you.
Thank you
Thank
very
you. I'm
much.
sorry I can't join
I
you
know,
on the
yeah.
forum. I have to do the same thing for as well. Thank you.
So please join me to thank Prof. Adeeba for this fantastic information sharing, and hopefully all of us will be enabled to do what we want in terms of helping the government, helping organization, NGOs, and helping people with HIV/AIDS. Right? I think that's also very important because especially among the healthcare practitioners among us, we need to do. And I think one of the things also we are worried that that this stigma Prof. Adeeba had mentioned seem to permeate even among healthcare practitioners. So something have to be done, in terms of the realignment, changing mindset, and so on. I think very important. Thank you once again, Prof. Adeeba, and look forward to see you again in the near future for another maybe webinar. And and all the best for your next webinar. Thank you very much.
Thank you.
And now back to Dolicia.